Morning all. My topic for today's presentation is approach to wrist drop and foot drop. Myself, Dr. Divya Davison, and moderated by Dr. Kiren George Ghosh. So coming to introduction, in a patient with wrist drop, usually the wrist and finger extensors become weak. And there will be unopposed action of flexor muscle causes appearance of dropped wrist with curling of fingers when arm is held out. And most common localization for wrist drop is a lesion of the radial nerve at the spiral groove. Similarly, foot drop is the weakness of foot dorsiflexion, and lesion of the common peroneal nerve is the most likely cause. Coming to wrist drop topic in proper. So the brachial plexus, we have a nerve roots C5 to T1. The posterior divisions forms from of C5 to T1 forms the posterior cord, and posterior cord gives branches to upper subscapular, thoracodorsal, lower subscapular, axillary, and finally it continues as radial nerve. So radial nerve is the largest branch of brachial plexus originating from posterior cord with root value of C5 to T1. It gives off the posterior sensory branches, posterior cutaneous nerve of arm, lower lateral cutaneous nerve of arm, and posterior cutaneous nerve of forearm in the axilla, along with muscular branches to 3 heads of triceps and anconeus. And after this, it enters the spiral groove along with posterior cutaneous nerve of forearm. So in spiral groove, it is situated in proximity to the humerus. So any immobilization or a fracture can cause easy injury to the nerve at this site. So most common site of radial nerve injury is at the spiral groove. And after that, it gives branches to brachioradialis at the elbow. It passes between brachialis and brachioradialis and gives muscular branches to brachioradialis and extensor carpi radialis longus. And also it divides into deep motor branch and superficial peroneal branch, which is sensory. So deep motor branch gives off muscular branches to extensor carpi radialis brevis and supinator. Then after this, it enters the supinator muscle at the arcade of Froese. It is the proximal border of supinator, which is tendinous in some individual. So it is a common site of compression of deep motor branch of radial nerve. So after giving branches to extensor carpi radialis brevis and supinator, it enters the supinator muscle and it becomes the posterior interosseous nerve, which is pure motor supply of radial nerve. This is a deep branch. And it gives the branches to extensors of wrist and fingers. Wrist and fingers. The superficial peroneal branch is a pure sensory branch and it gives sensory supply to the dorsum of the hand. So motor branches at the arm, it is 3 heads of triceps and also anconeus. At the elbow, it gives off muscular branches to brachioradialis, long head of extensor carpi radialis, and divides into deep and superficial peroneal branch. The deep radial motor branch, which gives muscular branches to extensor carpi radialis brevis and supinator at the elbow. And it become, after entering to the supinator muscle, it become posterior interosseous nerve and gives just to extensors of wrist and fingers, extensor digitorum communis, extensor carpi ulnaris, abductor pollicis longus, extensor indicis pro, extensor digitae quintae, extensor pollicis longus, and brevis. So main supply is extensors of wrist and fingers. Sensory branch at arm, it gives above the spiral groove, it gives branches to posterior cutaneous nerve of arm lower lateral cutaneous nerve of arm and posterior cutaneous nerve of forearm, and supplies the posterior and lateral part of upper arm and also the posterior part of lower arm. At the forearm, the radial nerve divides into superficial radial and deep motor branch. The superficial radial branch supplies the dorsum of the lateral hand and the proximal phalanx of the first three fingers and along the thumb. So this is the sensory supply. So even though the sensory supply of hand is supplied by ulnar, median, and radial nerve, it has got different zones, but there is an overlap between the sensory supply. So autonomous area is the area in which only the single nerve is supplying the sensory sensation to that area. So for radial nerve, the autonomous area is the web space between thumb and index finger over the dorsum of the hand. For the assessment, autonomous area we are using mainly because the other areas it can be overlapped by other nerves. For radial nerve, it is the web space between index finger and the thumb and the dorsum of the hand. Coming to clinical examination. So first we'll go to radial neuropathy at the spiral groove. So radial neuropathy the compression can occur above the spiral groove, at the spiral groove, and below the spiral groove at the elbow and the posterior interosseous nerve. So the lesions at the axilla and at the spiral groove, it's almost similar. So first we will discuss the radial neuropathy at the spiral groove. It is the most common site of compression of radial nerve because it is situated in close proximity to the humerus. So there will be wrist drop and finger drop due to the involvement of deep motor branches also involved. So extensor indicis proprius, the extensors of wrist and fingers are affected. So there will be wrist drop and finger drop. And there will be mild weakness of supination because of the involvement of supinator, and also elbow flexion due to the brachioradialis. The branches to the brachioradialis is also affected. Triceps is typically spared because the muscular branches is given after the at the level of the before the level of the spiral groove at the axilla. So triceps is typically spared. So in that case, the elbow extension is intact. Only wrist drop and finger drop will be there, along with mild weakness of supination and elbow flexion. Sensory, the main sensory branches, the posterior cutaneous nerve of arm, forearm, and lateral cutaneous nerve of forearm, it is given above the level of spiral groove, that is in the axilla. So the sensation of the lateral arm and the posterior arm, it is spared. So the sensory involved mainly is because of the superficial sensory radial branch, which supplies the lateral dorsum of hand, thumb, dorsal proximal index, middle finger, and ring finger. So sensory supply will be lost only on the dorsum of the hand. Others are spared. So in this case, ulnar and median innervated muscles will be normal, and there can be apparent ulnar weakness. That is, the abduction of the wrist and fingers appears weak. So in that case, we have to passively extend the wrist and examine. Otherwise, in a patient with the wrist drop and finger drop, abduction is also weak. Abduction of the fingers is also weak. So in that case, we have to passively extend the wrist, and we can examine the patient by placing the hand over a flat surface, and we can examine for the wrist and finger extension. Otherwise, abduction is also may appear weak in this case, but that is only apparent. Coming to etiology, at the spiral groove, the most common etiology is one is prolonged immobilization. So in Saturday night palsy, when an intoxicated patient he hangs the arm over the chair or a bench for a long time over the night, which results in compression of the radial nerve at the spiral groove and results in Saturday night palsy. So in this case, the presentation will be wrist and finger drop. And the other features we have explained in the above slide. And also strenuous muscular effort can cause the compression at the level of spiral groove, humerus fracture, any cast immobilization, and vasculitis. These are the etiologies at the spiral groove. Coming to radial neuropathy in the axilla. So it is similar to spiral groove lesion. So most common most common etiology is one is prolonged compression in the axilla, usually seen in crutch palsy. So the patients using crutches, there will be compression at the axilla. And additional features, there will be weakness of triceps also, because the muscular branch to the triceps is given above the level of spiral groove. So there will be additionally weakness of arm extension. So arm extension, finger extension, and wrist extension will be weak. Sensory, all three branches of posterior cutaneous nerve of arm, posterior cutaneous nerve of forearm, and lateral cutaneous nerve of arm, it is also given at the level of axilla. So there will be additional loss of sensation in the posterior arm and posterior forearm, along with wrist drop and finger drop. And from the posterior cord lesion, we can differentiate it by there won't be any weakness of deltoid and latissimus dorsi, because axillary in the posterior cord, the other thoracodorsal and axillary nerve, it supplies deltoid and latissimus dorsi. So by this, we can differentiate it from posterior cord lesion. Coming to posterior indrocious neuropathy, it is a pure motor branch of radial nerve. It divides, the radial nerve divides at the level of the supinator to indrotion. It enters the supinator muscle and supplies the wrist and finger extensors. So it mimics radial nerve entrapment at the spiral groove. In both cases, there will be wrist drop, finger drop, which sparing the elbow extension. But in posterior indrocious neuropathy, brachioradialis, extensor carpi radialis longus, brevis, and triceps, these muscles are spared. We all know that at the elbow, it gives muscular branches to extensor carpi radialis longus, brevis, and supinator. Then only it pierces the supinator and it becomes the posterior indrocious nerve. So in this case, wrist extension possible but weak and radially deviated, because extensor carpi radialis, brevis, and longus are spared. So in this case, only extensor carpi ulnaris is involved. So wrist extension is possible but weak, and it is radially deviated due to the in that branches to extensor carpi radialis. And there is no cutaneous sensory loss because it is a pure motor branch. Patient may have forearm pain because this some deep sensory fibers supplying the indrocious membrane and also the joints. So patient may feel some deep sensory deep pain in the joints because of this deep sensory fiber involvement. So coming to sites of compression of posterior indrocious nerve, it can be compressed at the level of medial proximal edge of extensor carpi radialis brevis and fibrous tissue anterior to the radiocapitellar joint between brachialis and brachioradialis. It enters between the brachialis and brachioradialis, where a fibrous tissue which is present in the anterior to the radiocapitellar joint can also cause the compression. And leash of Henry, in which the recurrent radial vessels that fan over the deep motor branch proximal to the supinator. And most common site of this compression of posterior indrocious nerve is arcade of Rose. It is the proximal border of the supinator. In some individual, it is tendinous. So it is the most common site of compression of posterior indrocious nerve, and it all at the distal edge of supinator muscle also there can be a compression. Coming to localization of wrist drop. So as we discussed in the above slides, it can be posterior indrocious nerve or radial nerve at the spiral groove, a radial nerve in the axilla. It can be posterior cord of the brachial plexus, C7 root, or even central nervous system lesions can cause wrist drop. What are the clinical differentiating features of wrist drop in various cases, various etiologies? So in posterior indrocious nerve, there will be wrist drop and finger drop, and there will be radial deviation on the wrist extension, because extensor carpi radialis and longus and brevis, the muscular branches are given before the level of before it enters into the supinator muscle. That is, at the level of elbow, it gives branches to extensor carpi radialis and brevis. So only extensor carpi ulnaris is affected. So there will be radial deviation of wrist extension. If the lesion is at the radial spiral groove, patient will have additionally mild weakness of supination because it gives branches to supinator at the level of elbow. And there will be weakness of elbow flexion. This is because of the brachioradialis. The branches to brachioradialis given at the level of elbow. And there will be brachioradialis tendon reflex will be diminished. When in case of a radial neuropathy at the axilla, there will be additionally weakness of elbow extension because of the involvement of muscular branches to triceps. It is given above the level of spiral groove. And also there will be diminished triceps tendon jerk. And coming to the posterior cord we know it also gives to branches to axillary nerve and also the thoracodorsal nerve. So the axillary nerve supplies the deltoid. There will be weakness of shoulder abduction. And also in case of C7 radiculopathy, there will be weakness of wrist flexion also. Coming to electrophysiology. So nerve conduction study, we will do usual radial motor study, ulnar motor study, medial motor study, and FA responses of median and ulnar, along with the superficial radial sensory study, and ulnar sensory study and median sensory study. For radial motor study, we are recording from the extensor indicis proprius, and stimulation is given at the level of forearm, elbow, below and above spiral groove. For ulnar motor study, abductor digiti minimi is recorded and stimulation is given at the level of wrist, below the groove, above the groove, when elbow is flexed. For median motor study, recording is from abductor pollicis brevis and stimulation is given at the level of wrist and anterior cubital fossa. For superficial radial sensory study, we'll record over the extensor tendons to the thumb and stimulation is given at the level of forearm. For ulnar study, digit 5 is stimulated and stimulating the wrist and recorded from digit 5. For median study, digit 2 or 3 is recorded after stimulating at the level of wrist. For EMG, we will do at least 2 or more muscles that is innervated by posterior interosseous nerve. That is extensor indicis proprius or extensor carpi ulnaris or extensor digitorum communis can be taken. Or radial innervated muscles, which proximal to the bifurcation or distal to the spiral groove. More than or one muscles are supplied. That is, at the level of elbow, it gives branches to brachioradialis and extensor carpi radialis longus. So at least one muscle we can test at the level of elbow. And proximal to the spiral groove, triceps or angonius. Angonius is, we usually do triceps sampling. For non-radial posterior cord innervated muscle, we'll do deltoid or latissimus dorsi. We are usually using deltoid. For non-radial C7 innervated muscle, this is to identify C7 radiculopathy. So in this case, additionally, non-radial innervated C7 innervated muscles will be affected. So we can either sample flexor carpi radialis, pronator teres, flexor digitorum sublimis, or cervical paraspinal to know the level of lesion. So this is the EMG protocol. Coming to the electrophysiology, in case of posterior interosseous nerve, there will be weakness of extensors of fingers. So either the extensor indicis proprius, extensor digitorum communis, or extensor carpi ulnaris, we can sample. We can see the denervation and renervation potentials there. And in radial nerve at the level of spiral groove, we can sample either brachioradialis or extensor carpi radialis longus. That is given at the level of elbow, that is below the spiral groove. For radial nerve at the axilla, we can sample. Additionally, we can sample triceps. For the posterior cord, we can sample deltoid. And for the C7, we can, to know the C7 radiculopathy, we can sample flexi carpa radialis or pronator teres along with the cervical paraspinal muscle. So nerve conduction study, there will be abnormal radial snap if it is axonal, and low radial CMAP is seen in a radial nerve in case of if it is axonal, and we can see the conduction block at the level of spiral groove if it is demyelinating. So conduction block between forearm and elbow seen in posterior interosseous neuropathy, it is rare. Most common site for compression is radial nerve at the spiral groove. So we can see conduction block at the level of spiral groove. That is below the spiral groove and above the spiral groove, the amplitude will be more than 50%. Coming to cases. First case, a 57-year-old male with a history of right humerus fracture, for which he has undergone cast immobilization for 3 weeks. Following the removal of cast, he noticed difficulty in extending his right wrist and fingers, along with sensory dulling over the lateral dorsum of right hand. On examination, wrist and finger extension were weak with grade 1/5. Elbow extension was normal. There was a sensory dulling over the dorsum of the hand or lateral 1/3. Reflexes were all present. This is the motor nerve conduction study.
The case here is a patient where having a wrist drop along with sensory involvement. So the involvement of radial nerve is more likely, and it is more uh, before the level of bifurcation, that is into superficial and deep, because the superficial branch of radial nerve supplying the lateral dorsum of the hand is also involved. So coming to the nerve conduction study, first is here depicted as a lower limb. So the right peroneal, there is an amplitude which is reduced by 2.7 with normal latencies, and velocity is slightly reduced. Whereas coming to and there is a good proximal pickup in the right peroneal. Coming to the left peroneal, it is uh, normal, and bilateral tibial and the right side is showing normal amplitudes with latency and velocity, and then the left side also it is showing normal amplitudes with velocity. Then coming to the upper limb, in the upper limb there is median nerve uh, which is normal, and right ulnar nerve again which is normal in the amplitudes with distal latencies and velocities also being normal. And the left median nerve is also showing normal amplitudes with velocity and normal distal latencies. So from this first part, it is only right peroneal distal amplitudes which are reduced with good proximal pickup. Then the left ulnar as well, amplitudes and latencies are normal. Coming to the radial nerve on the right side, there is reduction of the amplitudes with at the spiral groove. There is it is not recordable, almost like a conduction block between the elbow and the spiral groove. And F waves are all normal with snap amplitudes which are reduced. Sural bilateral amplitudes are slightly reduced. When compared to superficial peroneal nerve, bilaterally it is normal with normal peak latencies. Median nerves are bilaterally normal, and right superficial radial nerve is also, there is snap amplitudes which are reduced, and slight peak latencies which are increased on the left median nerve and preserved left ulnar and left radial peak latencies with amplitudes. So overall, with the nerve conduction, it is. Sorry, madam. Right superficial peroneal Amplitudes are normal. It is normal. Right superficial peroneal amplitudes are 9.1 and peak latency is 3.4. It is normal. So the nerve conduction report will be of a right radial neuropathy at the level of spiral groove, because we saw a conduction block, and as well as right peroneal axonopathy, right peroneal axonopathy, probably technical error also, because if the patient, we have to look into the EDB atrophy is there or not, because there was a good proximal pickup and preservation of the sensory. And there is a left median neuropathy also. Maybe because of the, we have to do a comparison studies to look for the CTS if it is there or not. Then the EMG was done. So EMG we will sample with whether, as we saw in this one, at the level of spiral groove is what we are looking. So the involvement of extensor digitorum communis, carpi radialis, and tricep and brachioradialis, and sparing of triceps will tell that the level of involvement of radial neuropathy will be at the level of spiral groove, and the above ones are spared.
So he showed the right radial neuropathy at the lower arm. At the spiral groove, in addition to bilateral medial neuropathy at or distal to the wrist. EMG showed active denervation from the distal radial innervated muscles. Coming to second case, 72-year-old male, non-case of hypertension, diabetes mellitus. There is a history of neck pain which is radiating to right upper limb for the past 1 year. Weakness of right upper limb noted for the past 6 months, with difficulty in holding pen and making boluses of wood. There is a wasting of right hand and medial forearm and arm. On examination, there is a right hand weakness, wrist extension, finger extension, elbow extension is also weak, and dependent reflexes, right triceps jerk was absent, sensory was normal.
So history is of 72-year-old male with comorbidities, with history of neck pain with radiation, and he has weakness of right upper limb with difficulty in holding pen, making boluses of food. Difficulty in holding pen could be due to a weakness of opponent's boluses or the finger flexors and the introcei also. And difficulty making boluses of food, also finger flexors and the introcei could be weak. And there is wasting of the right hand, the medial forearm and the arm. Examination, the right hand weakness, they have not mentioned whether the distribution of weakness, whether median and ulnar innervated muscles are weak or not. Intrinsic muscles.
All intrinsic muscles were weak.
So the median and ulnar innervated muscles are also weak. Wrist extension is weak, but the wrist flexion and elbow flexion is normal.
Other examination is normal.
Finger extension is weak, elbow extension is weak. So wrist flexion is also strong. So localization, this could be a lower plexus involvement. C7, C8, T1 innervated muscles weakness. Pure motor involvement, so anterior horn cell would be another localization. Other localization would be multiple radical involvement. Sees C7, C8, and T1. Still, the other median and ulnar innervated muscles of the hand are also weak. Also be coming to the conduction, the median latency, amplitude, and velocity is normal. There is no conduction block in the right median. Left median also there is normal distal latency, amplitude, and velocity with no conduction block. Right ulnar is also normal, and left ulnar is also normal. The right radial has reduced amplitude with normal latency and velocity without conduction block. And left radial is normal. So there is only right radial amplitude reduction. And right axillary and the musculocutaneous and suprascapular nerves are normal with normal F waves. And sensory conduction is so the median and ulnar sensory is normal, right? Radial radial sensory conduction is also normal. Rest of the sensory conduction is normal. From the EMG, right EAP and right triceps is involved. And right FDA and right APB is also involved. We can see that the left side also there is left FDA also showing reinnervation potentials. The right C6 paraspinal is also involved. So here there is a pure motor affliction. From the nerve conduction study, only right radial nerve seem to be involved, but from the EMG, there is involvement of the right median and ulnar innervated muscles and also the left ulnar innervated muscle also. This is more in suggestive with normal sensory. This is more in suggestive of left FDA reinnervation potential. From this nerve conduction study, there is possibility of anterior horn cell disease involving the cervical segment.
We can only say that's a consequence of practice. And you cannot say that geology is the residency. I can go to the all step by step. Everywhere we are trying to investigation. That is the more suggestive the purpose of this. Neck pain which is radiating to right upper limb. So there is a NCS showed reduced CMAP amplitude from right radial nerve. Sensory conduction was normal. EMG showed innovation and renovation potentials from the ulnar and radial innervated muscles along with the right C6. So it can be a radiculopathy. It's a radiculopathy, C7, C6 to C8 radiculopathy. Finger drop and along with the intrinsic muscles of hands were weak. Can be apparent weakness also. Coming to the next topic, that is foot drop. Lesion of the more common peroneal nerve is the most likely cause, and it occurs at the level of fibular neck. So clinically, patient will have foot drop and sensory disturbances over the lateral calf and the dorsum of the foot. The other causes which can mimic peroneal neuropathy is one is L5 radiculopathy, lumbosacral plexopathy, sciatic neuropathy, and anterior horn cell disease. So lumbosacral plexus, it comprises nerve roots from L5 to S3, and it also has got a component from L4. And anterior divisions forms the tibial part of sciatic nerve, and posterior divisions form the peroneal part of sciatic nerve. Along with it gives superior gluteal nerve and inferior gluteal nerve. The sciatic nerve, it exits through the greater sciatic foramen under the piriformis muscle. And it has got two-part tibial part and common peroneal part. Tibial part supplies the hamstrings, helps in the knee flexion, and also the ischial part of adductor magnus. The peroneal part of sciatic nerve supplies the short head of biceps femoris. And sensory, medial sural and lateral sural, it combines to form sural nerve, which supplies the lateral calf of the lateral calf of leg. Terminal branches, it finally divides into tibial and common peroneal branches. This common peroneal branches gives off a lateral cutaneous nerve of calf, which supplies the lateral side of the knee and upper calf. And it divides into superficial peroneal and deep peroneal nerve. This superficial peroneal nerve supplies the everters of leg, that is peroneus longus and peroneus brevis, and it supplies the sensory supplies mainly by medial cutaneous branch and lateral cutaneous branch that supplies over the lateral side of calf and also the dorsum of the foot. The deep peroneal nerve supplies the extensors of ankle and toes, and along with the peroneus tertius. So it supplies tibialis anterior, extensor hallucis longus, extensor digitorum longus and brevis, along with peroneus tertius. And sensory supply, it supplies the dorsal digital cutaneous nerve, which supplies the web space between the great toe and the second toe. Tibial nerve, which may mainly the plantar flexors, that is angle plantar flexion of the angle. That is motor supplies mainly to pronamus, soleus, plantaris, tibialis posterior, and also tibialis posterior is the everters, along with the tibialis anterior, along with flexor longus and flexor hallucis longus. Sensory, it gives off the branches, medial calcaneal branch, which supplies the heel region, along with the final terminal branches are medial and lateral plantar nerve, which supplies the sole of the foot. Causes of peroneal neuropathy, it can be external compression, direct trauma, traction injuries, tumors, vascular causes, or idiopathic. Coming to clinical examination, so deep peroneal nerve involvement results in toe and ankle dorsiflexion weakness. And superficial peroneal nerve involvement results in foot eversion weakness. Ankle inversion is preserved but may appear weak because it is supplied by tibialis posterior, anterior, and mainly tibialis posterior, which is supplied by the tibial nerve. And patient will have a slapping of foot and high steppage gait, and we can elicit tinel sign at the level of fibular neck. Sensory, patient will have mid and lower lateral calf. There will be sensory loss along with over the dorsum of the foot. And lateral knee sensation remain preserved because lateral cutaneous nerve of knee, which is given before the level of bifurcation to superficial peroneal and deep peroneal. That is from the common peroneal nerve. And there will be normal examination at the level of hip joint and knee joint, hip extension, hip abduction, internal rotation, and knee flexion will be spared because that is supplied by the tibial part of sciatic nerve and also the lumbosacral plexus, which gives of inferior gluteal and superior gluteal, which supplies the hip abduction, internal rotation, and also the hip extension. And reflexes will be normal in case of peroneal neuropathy at the fibular neck. If the lesion is proximal to the fibular neck, then there will be additionally involvement of tibial nerve. So weakness of angle inversion will be also present along with plantar flexion weakness and sensory loss over the lateral knee. That is the sensory branch, that is lateral cutaneous nerve of knee, which is given, which is supplied by the common peroneal nerve before the bifurcation. So there will be additionally sensory loss over the lateral part of knee. And sensory loss over the sole of the foot, lateral foot, and medial calf. So sole of the foot, which is supplied by medial and lateral plantar nerve, which is supplied by the tibial nerve, and also the lateral foot and medial calf. Any weakness of hip abduction, extension, or internal rotation, that is by the superior gluteal nerve, inferior gluteal nerve, which is directly from the lumbosacral plexus. Any asymmetry in the angle reflex also suggestive of any S1 radiculopathy, or the patient will have more proximal lesions. So coming to approach to foot drop, in foot drop there will be dorsiflexion will be weak. If it is eversion is also weak, eversion is normal, then it's deep peroneal nerve. Because the superficial peroneal nerve supplies peroneus longus and peroneus brevis, that is helps in the eversion. So if it is normal, then it's the site of lesion is deep peroneal nerve. If eversion is also weak, then we have to look for the plantar flexion. If plantar flexion is normal, which is supplied by tibial nerve, then the lesion is at the common peroneal nerve. Common peroneal nerve so supplies the both eversion and that is peroneus longus and peroneus brevis, which is supplied by superficial peroneal nerve, and deep peroneal nerve supplies the dorsiflexion flexors of the angle. So if plantar flexion is weak, then we have to look for plantar and knee flexion. If it is also weak, then it is sciatic nerve, because the sciatic nerve, the tibial part of sciatic nerve supplies the hamstrings. So there will be the action is knee flexion. So if it is weak, then we have to look for thing of sciatic nerve. If hip abduction is also weak, then we have to think of L5 segment or root. Coming to electrophysiology, in case of deep peroneal nerve involvement, there will be weakness of foot dorsiflexion, and in case of common peroneal nerve, we have to additionally there will be foot eversion weakness, and there will be sensory loss in the dorsum of the foot and lateral calf, because the superficial peroneal nerve supplies the dorsum and lateral calf of the foot, leg. And if sciatic nerve is involved, then we additionally patient will have foot inversion weakness because of involvement of tibialis posterior, and there will be additionally weakness of knee flexion due to the hamstrings involvement. And additionally, patient will have sensory loss in the lateral knee and sensory loss in the sole of the foot because of the involvement of lateral plantar and medial plantar, and also the lateral cutaneous nerve of calf. In case of gluteus medius or maximus weakness, then we have to suspect lumbosacral plexus which supplies superior gluteal and inferior gluteal. So gluteus medius is, helps in the abduction and gluteus maximus helps in the extension. Along with sensory loss in the posterior thigh. In case of L5 radiculopathy, patient will have additionally back pain and a positive straight leg rest. SLR will be positive in case of L5 radiculopathy. So for nerve conduction study, we'll do peroneal motor study, mainly the EDB, extensor digitorum brevis. Tibial motor study will record from abductor hallucis brevis and stimulate at the level of medial angle and popliteal fossa. For superficial peroneal study, recording is from the lateral angle and stimulation is given at lateral calf. For sural sensory study, recording is from the posterior angle and stimulation is given at the calf. Along with, we have to look for tibial and peroneal F5 response. Demyelinating lesion, there will be focal slowing along with the conduction block more than 20%. We are taking as 50% drop in CMAP amplitude, especially over the very short segment. So below, at the level of fibula and the lateral popliteal fossa, if there is a CMAP amplitude reduction, then we have to suspect a conduction block or a focal compression. In this demyelinating lesion, usually the sensory snaps will be normal. So distal superficial sensory nerve will be in a demyelinating lesion, the snaps will be normal. So this is a case in which we can see at the level of above the level of fibular neck, that is at the lateral popliteal fossa, there is a reduction in the CMAP amplitude. So this is a demyelinating lesion, probably due to the focal compression at the level of fibular neck. In axonal lesion, we can't localize the lesion. There will be uniform reduction in the CMAP amplitude, all stimulation site. And superficial snaps also, there will be reduced snap amplitude. Compared to the demyelinating lesion, usually snap will be normal. Patient will have sensory abnormality, but electrophysiologically it will be normal. EMG is mainly to confirm the localization and assess the severity of the lesion and to exclude the other causes of that mimic the foot drop, that is sciatic neuropathy, lumbosacral plexopathy, and radiculopathy. So EMG will do muscles which is supplied by deep, will sample muscles which is supplied by deep peroneal nerve, that is tibialis anterior or extensor hallucis longus, and superficial peroneal nerve, that is peroneus longus or peroneus brevis, tibial nerve, tibialis posterior, and common peroneal branch, that is short head of biceps femoris. Coming to EMG findings, deep peroneal nerve, there will be, we can abnormality, denervation or innervation potentials from tibialis anterior or extensor hallucis longus. In common peroneal nerve, additionally, the evertus of foot, that is peroneus longus, which is supplied by superficial peroneal nerve, will be normal. In sciatic nerve, patient will have additionally flexor digitorum longus and short head of biceps femoris is abnormal. In lumbosacral plexus, patient will have additionally, we have to sample gluteus medius. And also, we usually do gluteus medius. We can also do tensor facial lata. For L5 radiculopathy, paraspinal muscles can be sampled. Coming to cases. Yes. 71-year-old male, non-case of hypothyroidism, dyslipidemia, bilateral, non-case of bilateral, previous history of bilateral L5S1 radiculopathy. Patient had a paresthesia of both soles, which he presented with acute onset foot drop on the left side since 27th of August. He also noticed difficulty in inserting chappal and along with loosening of chappal without awareness. There is a history of tripping of toes while walking. He's able to drive car and he's able to apply pressure over the clutch. He also noted numbness over the dorsum of the foot. On examination, angle dorsiflexion, eversion, and extensor hallucis longus were weak. Plantar flexion, inversion, knee, hip, and movements were normal. Deep tendon reflexes were absent bilaterally. Only angle jerk were absent bilaterally. Knee jerk was present.
So this patient already had a bilateral L5S1 radiculopathy with paresthesia, now presented with acute onset foot drop. And so he had difficulty inserting chappal, which could be due to a dorsiflexion weakness. And then he had loosening of chappals without awareness. That may be due to the sensory numbness over the dorsum of the foot. And then he had tripping of toes while walking, which may be due to weakness of the toe extensors and toe flexors, toe extensors. And he is able to drive car. He is able to apply pressure on the clutch. That is, plantar flexors are normal, and he has numbness noted over the dorsum of the foot. And then on examination also, angle dorsiflexion, eversion, and EHL is weak. So that comes under the distribution of the common peroneal, because both the deep peroneal as well as the superficial peroneal is involved, because eversion is also weak, and rest of the knee and hip abduction and all is normal. So, and deep tendon reflex angle jerk is absent bilaterally, which may be due to the S1 radiculopathy which he previously had. So from the history, it is a common peroneal nerve involvement. So your achiever is he had an acute onset of foot drop. So can be a compressive entrapment neuropathy, which can be the most common cause of a neuropathy, or it can be due to acute onset can be a vascular event also. Vascular event. So this conduction, the left median conduction, motor conduction shows normal latency, normal amplitude, and the velocity. Right median is normal. Left ulnar is normal. Right ulnar is normal. Right peroneal shows prolonged latency, 6, reduced amplitude with no conduction block and reduced velocity. And left peroneal also shows mildly prolonged prolonged latency with the conduction block between above and below the fibular head. With the conduction velocity, slowing is seen, with velocity has reduced to 20. And the right tibial has a mildly reduced conduction velocity, and left tibial also has a mildly reduced conduction velocity. So from the EMG, it is a left peroneal, that is between above and below the fibular head, there is a conduction block. So entrapment neuropathy. It's focal diminution. In case of focal diminution.
And what is visible history is that you know, the explore waters that he was. It happened after he was 40 below. Happened after he was some robots. And we have also asked him how of people he said, yesterday was a walking, day to yesterday was a walking down. Then they make about this modest. Now that they have forgiven that, people have to make sure that it's fitting into the story. So it's actually good. That is. And that's what is this?
There is a conduction velocity of bilateral tibial is reduced.
Bilateral tibial and bilateral.
But it is not in the demyelinating range, not 30% reduction.
That's. Just. You're right, I don't think it's a focal delineation across the ruler. There's something else also going.
Like he might be having an HNPP kind predisposition for etiology is a patient. Localization in the left peroneal. That is
We know that there's a background still in face to that. We're also looking to see if that gets many. Too much of dehydration, see that you respect to the right formula. We would like to see how that is.
Then the peroneal left peroneal proximally also there is a amplitude reduction above and below the fibular head. And right peroneal is okay. The conduction velocity is also 29 in the left peroneal. Then F waves are prolonged in the right peroneal, in the right tibial, left peroneal, left tibial. Then in the upper limbs also, the left median, left ulnar, right median. So there is a diffuse prolongation of the F wave latencies significantly in the lower limbs, all the nerves. And snaps are in the left median peak latency is prolonged with normal amplitude. Right median is prolonged. Left ulnar snaps are prolonged with normal amplitude. Right ulnar also mildly prolonged. Then sural peak latencies are normal with slightly reduced amplitude, and bilateral superficial peroneal snaps are absent. So, so more than what we expected, there is a prolongation, significant prolongation of all the lower limb F waves in the demyelinating range. Upper limb,
F wave is 75.
75.
So we have the conduction loss. There we already know that's a big match.
And right peroneal also 68.
We know the judge for the something.
So only left peroneal is in the
Formal.
final localization. The patient is having a left peroneal focal demyelination is there. Along with that, this bilateral superficial peroneal is absent. bilateral sural is also reduced amplitude, which can be explained by the S1 radiculopathy that he's having. Sural should be normal. Snaps should be normal. Pulling snaps are also prone. So all those are decreased process is like a HNPP kind of exhibition.
Patient actually in 2009, patient had a paresthesia or the little finger on placing the arm over the chair. That time he had done this NCS, that time showed this similar finding except for the peroneal neuropathy. There was a prolongation of F waves and this was a new complaint. In between there was no progression.
Patient has a tendency for a entrapment polyneuropathy.
Yes, 70 minutes.
The idea is I thought he has a previous conception of the illusion of the sequence. All in the is very. Notice of the right around to there's a possible more than.
5.2.
5.2. That is approximate thickness.
But there was a because that almost can be attributed to the
Previously he had only paresthesia of the salt. Other than that, there was no weakness or along with the imaging finding also. MRI finding. No, not that. Final diagnosis is peroneal neuropathy at fibular neck along with polyneuropathy, demyelinating, but not in the demyelinating range. Etiology. Previously in 2009, he had done this NCS for this paresthesia. That time he had a similar conducting parameters. 2009. 1 month. 27/8, September 1st week, after 1 week. No, ma'am, he has sent for a UST of peroneal nerve. No. Patient was asymptomatic, so further workup was not done. Different. It can be a. It can be plexus because snaps are bilaterally abnormal. So we can't tell it is radiculopathy because of the snaps are also involved. Can be radiculoplexopathy. Underlying, underlying. Patient can have a HNPP. Right?
So she is football, and then, of course, they looked at the economics. So they formed the connection. And then this was your examination, right? Yes, I refused to do it. Almost the question. Right, you say the right solution.
Yes, acute presentation of foot drop, which can be localized common peroneal nerve at the fibular neck, along with a background history of demyelinating neuropathy. So this can be a part of underlying disease or a separate etiology. We have to evaluate for further. Previously, electrophoresis was done and CRP, other vascular risk factors has screened, but it is negative. No further work was done.
EMG is showing fasciculations from the left gastrocnemius and some reinnervation, slightly increased amplitude from the right TA. So left is having an S1 radiculopathy. So left gastrocnemius fasciculations can be explained by that.
Next. We are winding this today's session. Thank you.